We welcome you all to Talk the Talk. My name is Janine Stiene,
And I'm Toni-Ann Antoniato.
the Masters of Myofunctional Therapy.
Together, we interview physicians, dentists, and other professionals to learn how their expertise can benefit you, your child, or your patient's speech and language skills and complement the services they are receiving. We welcome Melanie Potock to this episode of Talk the Talk. Melanie is a speech language pathologist and feeding specialist. She is an international speaker on the topic of picky eating and feeding disorders in the pediatric population, and she is an author of 6 books. Welcome to the show, Melanie, and we're so excited to speak with you about all things picky eating.
Oh my gosh, it's my favorite topic. Thanks for having me.
Thank you.
No, thank you. We are so appreciative. It's also wonderful. We play these in our waiting rooms, in our offices. Obviously, not to mention the social media outreach, but it's an education that our parents get, our patients get, and then hopefully the masses get. So it's really wonderful to have you as part of that educational experience.
Thank you.
So before we go into all of the questions, if you don't mind sharing with us and sharing with the audience how you, as a speech language pathologist, follow the path into pediatric feeding therapy.
Sure, definitely. I was staying at home with my 3 and 5-year-old, and I had experienced my second child was pretty picky. And
Okay.
my pediatrician, well-meaning, tried to reassure me that all kids are picky, she'll grow out of it. And meanwhile, I was trying to figure out what I wanted to do in terms of changing careers. And I decided to go back to school to become a speech pathologist. I had to get a whole new bachelor's and a master's. And I specialized in augmentative communication.
Okay.
Got no education in feeding except for your typical adult dysphagia class,
Mm-hmm.
and ended up in the NICU.
Wow.
Because that's a typical path, right?
Yes, right. Yes. That
And
trajectory doesn't go together.
yeah, right? Not at all. Like, that is not the way we do it, but that's what happened. And it sounds cheesy, but it really changed my life. And I just discovered the joy of helping kids learn to eat, even those little babies learning to breast and bottle feed. And those kids often ended up on my caseload later once they were going to be introduced to solids, etc. But I really think it was my own experience as a mom of a very picky eater that got me thinking the way I do. And that was over 25 years ago. And here I am.
Wow.
Wow.
It's always nice when there's that personal aspect. And I feel like that's so much of how our careers develop and, what gets us into myofunctional therapy and other therapists into
Yes.
specialties. And it's that personal experience a lot of the times.
Definitely.
But yes, it becomes something that they can relate to
Mhm.
and therefore are so successful at.
Mm-hmm.
So parents are always doing what they think is best for their child. However, sometimes what we think is best, or what we've been told by others or by other feeding specialists, and they're not getting the support that the child really needs. What would you say is a common misconception when it comes to what parent thinks is best when it comes to specifically picky eaters? And is there any advice you would give to those parents who have those thoughts?
Yeah, and I think what you're saying too is that we get advice from all aspects of our lives when we're concerned about something, right?
Yep.
Whether it's, I don't know, he doesn't seem to do so well in math. I think he's doing fine. All kids get math at a different time, at a different pace. Like, you get that kind of reassurance from neighbors, from even sometimes from teachers, from maybe grandparents, and we're trying to make everybody feel okay about the situation and give it more time.
Yep.
But I would say that's the number one pitfall that we run into when it comes to picky eating, because picky eating, even in the research, is not well defined.
Mm-hmm.
And so it's more of an umbrella term. And that's how we get into these well-meaning phrases like, oh, all kids are picky. I'll grow out of it. Oh, don't worry about it. You were so picky too.
Yeah.
But all that's doing is delaying that child's ability to find the joy in food. And when I explain to perhaps very well-meaning pediatricians or a school teacher who kind of has the attitude that all kids are picky, that, actually 1 out of 4 typically developing children will develop a pediatric feeding disorder, typically developing kids. So when you think about the 4 kids that are playing in your backyard right now, maybe one of them is going to have significant challenges with food. So would we take that kind of wait and see, all kids are picky kind of attitude if we really knew this was going to become something more challenging? No, of course we wouldn't. We don't take that approach with other healthcare issues in children, and we shouldn't take it around food. But the problem lies in the term picky eater, because you can have your garden variety picky eater or you can have your extreme picky eater, but they're still both picky eaters.
Yeah. And I think parents tend to make a lot of excuses when it comes to their child being a picky eater. They don't like that food. They had it once and they vomited, so now they'll never eat it again. Instead of just truly identifying that there's something more going on that is not what meets the eye. Your father was a picky eater. They kind of try to make excuses for it. Because I'm sure, as a parent, I would be mortified if I said all my child eats is chicken fingers and French fries and nothing else. And I think that's some of that stigma that comes around when it comes to a family member discussing a child with picky eater, that is a picky eater or struggling, and making excuses, because I don't think there's enough education about everything underneath that has to be developed in order for that child to be successful with food.
Well, you just really hit the nail on the head, and that they're trying, well-meaning, compassionate, loving parents are trying to find reasons and reason out of the problem. But if you don't have the even baseline of knowledge of feeding development, which not all parents do, of course, then you can't find the reasons. But yet all kids are picky. So it's very hard to problem solve when you don't know what flags to look for that maybe are not typical. So you can see how they get spun up in that. It's like, it's nobody's fault. It's an easy trap to fall into. And then they fall deeper and deeper, and it's harder to climb out.
Yeah. What would you say are some of those early red flag signs that you can look for?
Yeah, I list a lot of them in all my books. So just off the top of my head, I'll give you 2 or 3 for each age. But for infants, of course, it's discomfort with feeding, it's losing weight, it's dysregulation around feeding. Really, though, feeding is stressful for both the baby and the parent or the caregiver. For babies just starting solids, it would be disinterest in food, extreme amounts of gagging. We know a little bit of gagging is to be expected, and in some ways is a good thing, but it's not a foolproof way of preventing choking. So, gosh, it just seems to be having more difficulty. And I'm going to say it again, it's stressful for the child and the caregiver. And then for older kids, even when they move into that natural phase of more hesitant eating closer to age 2, it's that the amount of stress that it brings to the family and to the child is out of proportion for the situation. That's what I always tell parents. Like, if you're really worried about this, go to your pediatrician, talk about the specifics. But the number one thing to say is, I'm stressed about this. Stress that you're stressed.
Right.
Because this is a relationship. Feeding is a relationship. And even if you get an evaluation through perhaps your clinic, and maybe you just give them a few tips and say, come back and see me in 2 months, and don't feel the need for weekly feeding therapy, that is a gift. To be able to walk home with that knowledge and not have to reason out of it. So nothing wrong with getting an evaluation, especially if it's stressful, because that's impacting your relationship with your child and the whole family.
Right.
Do you find that you see, and I think we see this, Toni-Ann, that the pediatricians are not concerned about feeding, especially if the child's gaining weight, even though how they're acquiring nutrition may be tough, and the type of nutrition that they're acquiring is next to none? how do you address that to a pediatrician when you say, I'm concerned about I'm concerned about my child, and the pediatrician says, well, their weight is fine, so don't worry about anything else.
Yeah, I'm glad you mentioned it, because what the pediatrician is really trying to do is just help that parent feel better and relieve some of that stress. Pediatricians love parents. They love the children. They're in this profession for a reason, and they want to help. But their first instinct is it's probably just a stressed out mom,
Yep.
and and I understand that. And my brother's a pediatrician. My best friend is a pediatrician. My co-author is a pediatrician. That's one of the most wonderful professions out there. However, when you feel like there isn't the communication and we're not able to communicate to that wonderful professional that it's more than just the growth curve, then I really recommend that parents go to my YouTube channel and they search on the playlist that's called Pediatrician Advice. And several of the tips on there, I'll give you 2 or 3, help with this issue. First of all, take pictures of your child's plate before you serve it, or after the kids do family style, like take a quick picture. Obviously, you have to be a little subtle about it. Take a picture, and then take a picture once it's back up on the counter and you're ready to clean it off. And keep a visual log of what's been happening for at least 3 or 4 days. Also, if you can, without making it too obvious, take a little video of your child. Because when you can share that video or those pictures, a picture is worth 1,000 words, with the doc, they start to see, oh my gosh, they really are eating fish crackers every meal.
Right.
And probably nothing else, right?
Yep.
It's like, oh, okay, I got a better idea here now. And then schedule a separate appointment without the child there, even if it's just a telehealth appointment, where you can share this information and it's very clear. I want 15 minutes to specifically talk to you about my concerns about my child's nutritional health. My child's nutritional health, not growth.
Right.
Yeah. So hopefully that's helpful
Yeah,
for your
that's a
kids
great
as
tip.
well.
No,
love
that's
that.
me too. I think that's perfect. That's a great place to direct, because that's always what you're looking for. It's just be able to say, look here, this can give you some insight.
Absolutely.
Yeah.
For parents who are trying to avoid any type of picky eating with their child, what would you say are some important things to do when you're first introducing solid foods in that, toddlerhood, and, transitioning from the bottle into solid foods?
Yeah, when you're first transitioning into solid foods, typically right around the 6-month mark, the most important thing is to begin to introduce variety as quickly as possible. That's not true for allergens. That's a totally different topic. But it's so easy for us to watch our little one eat pureed pears for the first time, or a slice of pear, that's been cooked and it's really soft and squishable. And the next time go, well, you really like pears. Let's do that one again.
Yeah.
And it's a trap we all fall into as parents right away. Well, I know, like that, so give them the chicken nuggets, even for our toddler. I always want parents to think variety, not volume, because volume is not really much of a thing when you start solids. It's about little samples, little tastes. It's tasting off your fingers. So the more variety you can offer, and you don't have to wait several days between foods. We don't do that anymore. We do that for allergens, but again, that's a different topic. And as the child begins to progress through feeding development, even into the toddler years, where they will stop taking in as much volume because they're not growing as fast, do you know what you focus on? Variety. Variety, not volume. That's how kids emerge out of that natural phase of more hesitant eating around age 2, that by about age 3, in the early preschool years, they will become more adventurous because you as a parent or caregiver focused on variety.
Right. And when we do that with the variety, it's allowing the variety to not only be taste, but also the textures and the consistencies, which is helpful.
Yeah, exactly.
That makes sense. It makes sense a lot, actually. So one of the things we see with our picky eaters is they begin to eliminate foods that they loved. which can be stressful and problematic for the parents. What do you recommend when a child who has a limited dietary repertoire starts saying they don't want something that they used to love?
Sure. All of us have the experience where we eat leftovers after a couple days, and by the third day, we're like, I'm so sick of lasagna, but we loved lasagna 2 days ago,
Yep,
right?
that's so true. Yep.
And for those kids who have a very limited repertoire, that's what happens or something gets associated with it, like they bit their tongue, or they had a little bit of a stuffy nose and it didn't taste as good, or a little bit of reflux or something, where it's like, oh, I don't like this as well today. And it doesn't take much for our pickier eaters to suddenly say, I don't like that. However, it's also very appropriate for that 2-3-year-old set to start saying no to things. They're supposed to, it's part of their cognitive development. So what we do is we don't panic, but we take like a 3, maybe a 4-day break from the food if nutritionally we can do that. We're assuming there's 2 or 3 other foods the very picky eater could eat, or milk, something like that, to give that nutritional boost. Then when you reintroduce the once loved food, introduce it in a super small sample, like maybe a teaspoon to a tablespoon. If you want, you can also introduce it in a new, fun, and creative way. Maybe it's some fun new food picks, or fun new silicone container, or whatever you want to do. But recognize that you don't want to make a big deal about the new container, because that can feel like a little overwhelming to those kids. And then they're like, oh, I'm not eating this now. Like, you're making too big of a deal about this. So you have to be sort of sly about it,
Okay.
and just see if they notice it and say, oh, I know those toothpicks are so cute, and then change the channel and move on. The
Yeah.
kids have already become interested because of the new toothpick.
Yep.
You don't need to be like, yay, new toothpicks.
Yeah,
Which I
right.
think we tend to want to cheerlead them through it, and that actually can backfire. So take a break, reintroduce with a very small sample. If they don't eat it, don't worry about it. It's not a waste. It's how we're going to get back to loving it. It's a small piece. And if you'd like to, maybe in a fun, creative way, but don't make a big deal about it.
Right.
So I was always thinking, and tell me if there's any truth to this, is that 2-year mark is where we often see that picky eating, because that's ultimately, especially from the Myo world, ultimately where we see that infantile swallow pattern maturing. And especially for tongue thrusters who need Myo, it's that prolonged habit of thrusting their tongue when we're swallowing that now starts to carry over, and they haven't developed the muscle strength, the jaw grating abilities, and the abilities to do all of those things, thus making them picky eaters by default almost. And just thinking about it from the perspective of along the stages of development, had they developed into their adult swallow, then picky eating may not have been an issue. But being that they have this tongue thrust and it's creating and perpetuating that swallow, is that what's necessarily causing them to have difficulty or be aversive to certain textures and consistencies?
Well, first of all, that is a really good question. And I think it illustrates how complex pediatric feeding disorders are,
Yeah.
because it's rarely just one thing, right? And when we assess these children, we're looking at the whole child as well as the whole family and the family dynamic. So it's really possible, sure, that you've got a kid who has continued to present with more of a tongue thrusting pattern longer than they should. Meanwhile, parents are starting to offer more advanced foods because that's what the big brother ate at this age, kind of thing. And the little kiddo isn't capable motorically to do it.
Yeah.
But that can then snowball into a bigger situation depending on the family dynamic, and the fact that, and this would be true regardless of tongue thrust, and the fact that after the first year, growth slows down significantly. And here we've got this little kid who's like chowing down and watching them gain weight. And we're so used to like saying, yeah, you can have some more, because they're saying they want more. Now it starts to slow down, and because their growth slows down, their appetite will slow down. So we have to be sure after age 1 that we have the kids on a regular meal and snack time schedule with at least 2 hours roughly in between eating opportunities where they're just having water, unless there's a medical reason to have something else. So they really do start to listen to their hunger cycles. I mean, that's the premise of responsive feeding. And that responsive feeding approach starts at birth. But the babies have that drive typically, where when they move into the second year, growth slows down, appetite slows down, and they're two.
Yes. Yep.
And no, like I
Yep.
know how to say no now. And I
Yep.
recognize the fact that, mommy, I am different than you, and my behavior influences you. Watch this.
Yep.
Watch what I can do to influence your behavior, mom.
Yep.
And emotions are big, really big. So it's all of that into one snowball that can really drive you into the depths of picky eating. But I love the fact that you have brought up the importance of the oral facial complex and development in terms of the motor skills needed to advance to other foods. Otherwise, the kids just get stuck on those meltables that they can squish and swallow, right?
Yep. That's every one of our myo patients.
Right.
Yeah.
If it can break down with saliva, it will, that's what they will eat. If it doesn't break down with saliva, then they're spitting it out.
Right.
Or they're saying they don't like it.
Too
Yeah,
effort.
it's just hard. It's hard to eat. They don't understand, they're like, I can't do this. So no, I don't want it.
Yeah. It's so interesting because I don't think as parents, we expect what you just said about the 1 year, the growth slowing down and the appetite slowing down, because you think my kid's getting older, my child should want to eat more, when it's actually the opposite.
It's actually the opposite. That's a great point, Toni-Ann.
That's actually,
which I'm sure is, very helpful for parents to know, because then what they do in response to that could be causing them stress when actually this is appropriate. Your child's supposed to be eating less now.
It's also a great loop back to that idea of taking pictures of the plates to show to the pediatrician. The reason why I recommend 3 to 5 days is because toddlers sometimes barely eat anything on a Tuesday, and then on Thursday they're like chowing down, and you kind of go, oh, actually they do eat a lot,
Yeah.
But all you remember is the stressful day where they barely ate. But they're also different, and we have to respect the fact that that's a challenging time, those terrific twos. But most kids
terrific twos, huh? Wow, that was very kind.
But most kids should emerge out of that natural phase of more hesitant eating by at least 3.5, if not age 3.
Okay. And the same things, let's say there is no history of picky eating for this child, and 2 comes around, and now they start, using that no word and showing their preferences. Would you say similar recommendations in terms of the variety again, and, not introducing it for a few days, same kind of things would apply?
Lots of variety, rotate through foods. And if they have highly preferred foods and they have semi-preferred foods, like, well, sometimes he'll eat that, but he really likes this. Offer more of the sometimes he'll eat it. And don't offer it with the highly preferred food, because,
he's always going to go.
I eat the highly preferred food, right? And then I get kind of full on that, and I may not take that one. The trick is actually to offer more sort of foods. These are okay with brand new foods that they aren't going to be as keen about, or they might surprise you. It makes this food look pretty darn good. I mean, I'm not saying serve a raw oyster on the side. I mean, maybe on the test buffet, but for the most part, don't shy away from the sometimes foods, because the way you get them to become the highly preferred foods is to serve them more often, either on their own or with a brand new food, because psychologically, the other one, the sometimes food, is more tempting to eat. Does that make sense?
Yes, absolutely. Absolutely. Is there an age when you feel they evaluating for picky eating, or that a patient should see a feeding specialist if they know or they suspect something's going on when it comes to their child's feeding.
After solids, you mean after they're introduced to solids?
Yes.
Yeah, for children who have just been introduced to solids, typically right before the 6 month, on the 6 month birth date, right around there. If you aren't seeing progress within 6 weeks, I would contact your pediatrician right away, unless you notice them losing weight or having other medical issues. But I just mean in terms of really being interested in food, being comfortable swallowing, gagging a little bit each meal just because it's new, but they keep going. It's no big deal, like
Okay.
tripping and running up and skipping off to the park, right? A
Yep.
little gag, but we just move right on. We're fine. But if you see them gagging a lot and really in distress and being really fussy about eating, and that goes on for, I mean, I'm saying 6 weeks, but I suppose I might even be a little more cautious than that and say a month.
Okay.
I'd at least be talking to my pediatrician and giving them the heads up that this is what I'm experiencing. For the older kids, we kind of went over it, but I would say in that first introduction of solids, that's what you're looking for.
Okay. Yeah. A lot of the patients that we evaluate with myofunctional therapy, they're 5 because that's typically when we'll do the myofunctional evaluations. And a lot of the times when we're getting a dietary repertoire inventory from the parent very much so can sometimes say things like, oh, eats like a typical 5-year-old,
Right.
pizza, chicken nuggets. And we're doing, let's dig a little deeper and we ask more specific foods. And sometimes we have to, even though as the therapist, we already know they are limited, we go through foods and, ask yes or no. And sometimes it's more about making it apparent to the parent that actually this child is limited in their foods and that there should be a better variety. Do you find that you see that often where they go to that, typical 5-year-old diet kind of situation?
Yeah. I do. On my free download page on my website, there's a tab that says free downloads or free toolbox. There's a chart that I have all my parents download, and any of your listeners can download it and use it for free. Just keep my logo and stuff on it. And that's what I start with, is list all the foods your kid loves. And, if they're coming in to see me, it's like maybe 8 foods, maybe 4 foods. It's not a lot.
Right.
And then the second column is foods my kid sometimes eats. Like, we're at the park and the kid is starving and the only thing I have is the blueberry Nutri-Grain bar, but they always want raspberry. Maybe in a situation like that, they'll eat the blueberry. That's a sometimes food. Okay.
Right.
And then the third column are foods that we're going to start working on in therapy. So we'll fill that in together after we learn a little bit more about the child and the relationship around food. But the fourth column is foods my family eats often. We're not going to list everything, but we all have go-to foods. Like a lot of families will say, yeah, every Friday night you have pizza and movie nights. Okay, what kind of pizza? Oh, it's always Domino's. Okay, does it have pepperoni or no, cheese? I need to know all those details. But at least I know that every Friday night, that extreme picky eater is being exposed to pizza, even if they don't eat it. And that tells me I can build from there. I want to find out what vegetables keep showing up. And the point here is that we can keep track of how often we give the kids the same food. And parents are often surprised if, say, the highly preferred food is chicken nuggets. The dad might say to me, well, I don't really give him chicken nuggets that often. And maybe he doesn't. Maybe he only does it 3 times a week. But mom lives in another household and she gives him chicken nuggets 3 times a week. And the babysitter gives it to him for lunch. And grandma gives it to him at dinner at her house. And the daycare serves it twice a week. And before you know it, we've had a lot of chicken nuggets. That also comes into play because that's not variety.
Right.
Yeah.
That's great.
Yeah. All right. So talking about cups now. So we can all agree and say no to the spouted sippy cup. And they have no place with proper orofacial development. Is there a type of cup that you would recommend at specific ages to support their overall oral musculature?
I get this question all the time. I would say
Okay.
at least once a day, to be honest with
No
you.
way.
People
Okay.
like Instagram, and it's phrased in a little different way, but it's typically, what's the best cup for milk for my 9-month-old? What's the
Yep.
best cup for water for my 18-month-old? That kind of thing.
Mhm.
And I like that that we're being careful about what we're choosing, but what I really want parents to think about is features, not a specific brand, etc.
Mhm.
Okay.
If we narrow it down to open cups and straw cups, we can introduce straw drinking as young as 6 months of age. I typically don't introduce it at the exact same time as open cup. I usually give 4 or 5 days break in between until they've kind of got that motor pattern down. But I usually start with straw drinking. You don't have to. It's just me. I like to do it that way.
Mhm.
And on my free toolbox tab, there's a 10 steps to teaching a child to drink from a straw. I'm a big believer in breaking things into tiny steps to help kids make progress faster. And then in terms of features, I ask the parents, do we think your child needs handles? Some kids don't like handles, other ones really love it.
Mhm.
Let's try to get a cup with removable handles then, right?
Right.
Let's try to use a straw cup that does not have a valve in the straw, because we know, I'm preaching to the choir here, but we know that promotes that suckling, that anterior posterior movement that we see babies doing under the breast and bottle. A little different under the breast, but you can really see it, especially under a bottle.
Mhm.
And we don't want kids to keep sucking like that, because that's not the natural progression of feeding development. So a short straw, my rule is tip of the straw goes to the tip of the tongue at rest. And we know our tongue should be at rest behind our teeth, even if they're just imaginary teeth at the moment, right?
Yep.
So tip of the straw to the tip of the tongue. Can we start with a longer straw when we're first learning to straw drink? Absolutely. But if you stick with the longer straw, you just have a spouted sippy cup.
Yeah.
Right.
Because whether it's your thumb or the spout or the long straw, they're all holding the tongue down and preventing the important elevation that we need to develop that more mature swallow pattern.
Mhm.
The other features to consider, of course, are whether you would want plastic versus stainless steel versus silicone, and there's pros and cons to each.
Mhm.
So what I've done is I have them listed, my tested cups and preferred cups, on my Amazon shop. Uh, and if it's not on there, either I didn't approve it, or it's only available in the UK or something, and so it's just
Mhm.
too obsolete for me to offer to everyone.
Mhm.
But I really ask parents to look at features before I talk about brands.
Mhm. Yeah.
Do you and when you're doing an evaluation, are you looking at any underlying medical conditions, especially if you're intervening at 6 months old, and they haven't really been exposed to a lot in that moment, or even when you're speaking with the pediatrician? Are they checking that the frenum isn't short? Are they sending them for an MBS or some type of swallow study, depending on age? Are you seeing that happening? I know the insurance companies, once in a while, when we're making a case for feeding, they'll want to see some objective measures, which again, you're not going to see anything happening in the oral stage, which is what we're obviously targeting. But as a feeding specialist, is there certain things that you are looking for that could be underlying or contributing to their feeding issues? And what kinds of things would you utilize?
Always, there's so many to consider from a physiological standpoint,
Okay.
and keeping in mind that physiology can include sensory processing, can include anxiety as part of physiology, but I'm talking about physiology, for example, like the GI tract, constipation, vomiting, reflux, aspiration, that kind of thing. So we really take a look at that first through a very thorough history,
Right.
really being a good detective, asking a lot of questions. But and I really want to stress this to everyone, especially if there's some new therapists listening to this as well. You got to be careful not to jump on a concern. And, the old saying of looking for zebras versus horses, you got to be really careful not to get too focused on a medical concern at first, unless it's blatantly obvious, I like to see that child for a couple sessions, give the parents a few strategies before I think about referring out or talking to the pediatrician about that. Because I need to provide enough information to that other medical professional and not just go on a one-time conversation when I first met the family. A lot of misunderstandings can happen that way. And it's a misstep that fresh out of school therapists make a lot because they're trying so hard to help, right? Although we don't want to delay, if it's not blatantly obvious, I like to spend a little more time being a detective. So I'll see that child for the assessment and maybe one or two more sessions before I start to think about that. I will say to the parent, I'm really considering that we might want to see this other professional. Let's give it a couple more sessions and keep talking about it, and we'll make a decision. We'll have a conversation together, and then it's your decision what you would like to do. So that's usually how I approach it.
And that I'm sure helps too, just with the rapport with the family. You know, sometimes it's hard to throw out so many referrals at one time. And like you said, some therapists, of course, are doing that because they want to do what they think is best for that family. But sometimes you need to build that rapport and that relationship and that trust so that you can have that more open conversation.
Because think about it for just a second. If you step into those parents' shoes, if it's blatantly obvious, they're going to agree with you 100% that we need to go see the neurologist or we need to go see the gastroenterologist, whatever it happens to be. My kid's vomiting all the time. Of course, we need to do that. But if it's not, and it's a flag, and we're kind of, oh, that's interesting. Let's keep an eye on that. Here's what it might be about. We could certainly say that, a little bit of that. If I were to say, oh, well, you know, that could be EOE, or it could be FPIES, or it could be gastroesophageal reflux disease, and da 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 da. Most parents, and I would do this too, are going to be thinking, you just met me. How do you know this about my kid? Like, you're kind of overreacting, Melanie. Do you see where I'm coming from here?
Yeah. Oh, I'm guilty of that. So I completely appreciate what you just said.
Well, it's because we see so many kids, so our brain goes there right away, and we're trying to help. But when, from the parent perspective, we actually kill the rapport by doing that. And if we can allow for a little more time and let them know, wondering about this, let's just keep an eye on it. I just want to let you know what I'm thinking. But let's see where we go here with this. Call me if you also see these things, and I want to see you sooner. But just FYI, I always want to tell you what I'm thinking. They appreciate that.
No, I can imagine that to be. Do you ever have patients that say they'll do it for you in the office, but they won't do it for me at home? And how often does that happen?
That is like, it's going to be on my tombstone.
Exactly. Yeah. Nope, they don't do. Yep.
And when I teach courses, that always comes up from the audience. And I teach a whole module on how to make sure that doesn't happen.
Wow.
And the key really is for any parents listening, to, rather than the therapist working with the child and then sending home homework for the parent to work on, is instead to bridge that empty space, that gap. So it's therapist works with the child, we get the parent involved as soon as possible, we work together with the parent and the child, and then we slowly fade away. We're in the same room, but we're more just observing. And the parent is now the therapist, and the kiddo's going, oh, I do this for dad too. Right? Then we transfer it to home. Because just changing to the new environment ups the ante for the kid, and it's much harder. So we've got to make sure that it's clear. Yes, I do this for mommy and daddy too, and Mel's just back here observing now. So we can do other things at home, like cook together and play in food and do all the fun sensory experiences. We could start those right away. But the actual interactions, tasting, licking, biting, chewing, swallowing, those come later in therapy, once they're doing it with the parent in the therapeutic setting, even if you're making a home visit.
Got it.
Yeah,
Okay.
that's great. Perfect. So we went into cups, and then another topic that we get a lot as speech pathologists is the pacifier. And some people think that as speech pathologists we are anti-pacifier, and we're not. There's an appropriate use and time of use for that. What are your thoughts in terms of pacifiers? We have feelings in terms of the right type of pacifier and the use of utilizing it in therapy, but up until a certain age, we like to wean our pacifier use by 6 months, which I think is on an earlier scale than, a lot are by 12 months. So what are your thoughts on that?
I love a good pacifier.
Yeah.
Love a good pacifier. I just had my first grandbaby, and
Oh,
we introduced the
congratulations.
pacifier pretty early, even with
Yeah.
breastfeeding. And I'm not saying everybody should do that. Every situation is unique, but we all really be encouraging them to wean during the daytime by 6 months. Then if they would like to continue to 12 months for nighttime use only, we do have some evidence that that is preventative for sudden infant death syndrome. Primarily though, during those first 6 months, but there is a little bit of support still after 6 months. So that would be okay. But remember that that's just when the baby falls asleep, and they don't have to keep replacing the pacifier all night long. So the duration, the frequency, the intensity of suck, all the things the three of us talk about, when the baby has a pacifier in the crib at night only or for nap time, it is so brief. It's just helping them regulate for a second to help settle down, to put their own selves to sleep. Or if you got a kiddo who's really getting hooked on their thumb, and that you're like, I'd rather have a little bit more pacifier right now and try to not make the thumb so interesting when they really need it for sleeping. So every child's a little bit different. I have a whole course on my on-demand library about pacifiers, which ones are the best ones, how to wean, etc. But to answer your question, when I worked in the NICU, the pacifier in most hospitals, I won't say the brand name, but it was flat and short with a little plastic shield.
Yeah, I know exactly which one.
Yeah.
That one.
Yeah.
And my kids had it because I didn't know any better back then.
Yep.
And I started to learn more, and the OT and the PT and myself, the SLP and the NICU, worked really hard to get rid of those pacifiers and we happened to use the Avent Soothie, but we wanted to get a pacifier that was, I think of it almost like pinky or pencil shaped, cylindrical, but you also want it to be all one piece of silicone. And the American Academy of Pediatrics stressed this because once the kids do start to keep it in their mouth, and even if they're just hanging onto the crib and starting to pull themselves up, that plastic shield, that's one of the number one reasons kids go to the ER for lacerations. And of course, many toddlers don't wean from the pacifier as early as we would like, and they toddle and they fall. So the all one piece silicone is really important. It's also more hygienic. The other thing I wanted to be sure to stress is when I first started writing books, I thought, this is a while ago, but I thought those little animal pacifiers were adorable. And then as I've revised my books, I have a totally different opinion because I needed to see them being used in my practice. Oh, they're just so cute. I love that one with the giraffe, And the more I watched, the more I realized I'm not convinced that the weight of that animal isn't contributing to this child's facial changes in facial structures. I don't know, but I'm observing this. So I'm wondering about it. But from a practical standpoint, let me break it down. Another reason why I never want anybody to use an animal pacifier. The American Academy of Pediatrics says that you cannot have stuffed animals, blankets, pillows, loose objects in the crib with the baby up to the first birthday. That means no animal pacifiers. So then if we are going to wean them from the daytime use of the pacifier and only use it at nighttime, you still can't use that pacifier. So it makes no sense from a practical standpoint.
Right.
However, for parents who are, please don't freak out, anyone listening, but if you're listening and saying, like I need to wean off this pacifier and my kid's over a year of age, let's say he's 18 months. I'm not against that animal pacifier for a brief time so that we can use the animal as a transition object, cut them off the pacifier, we get rid of the pacifier, and now they can take that lovey to the crib with them.
Yep. Okay.
Just pay attention that they don't start sucking on the animal
Mhm.
because that's not a solution either.
Yes.
So it's the old story, what we've been talking about this whole time. Like every child is unique. There's not a one way to do it for everybody. And every family has different needs. And we just try to guide them the best we can. But I think if we get too black and white and hard and fast rules about it, that we're not helping anybody. I think we have some general guidelines that make a lot of sense. And we help parents achieve it as they can at their own pace whenever possible. We might nudge along a little bit.
Is there any, or would you say you see a correlation between shortened frenums or minimal space in the airway or enlarged tonsils or congestion and allergies? Do you see anything more specifically or more regularly when you're doing feeding evaluations?
Yes, but you have to keep in mind that I don't get kids on my caseload that are good eaters, right?
Yep.
So yeah, I'm going to see more of that. I have to be very careful with my background in myofunctional therapy that I don't approach every child as if they have a myofunctional disorder.
Right.
You know, if you have a hammer, you find a nail kind of attitude. Like I really need to make sure I don't do that. But yes, I mean, so many of the kids who come my way, if I'm really going to look at the whole child, I'm probably going to find something like that. The way I explain it to the parents is pediatric feeding disorders, or even if you want to get into ARFID, that might be true too. But pediatric feeding disorders are never one ingredient in the salad. It's not just tomatoes in the bowl, right?
Right.
It's always like a little bit of this, a little bit of that, a little bit of this. And then we have to address all the ingredients. And some kids have like a lot of ingredients and other have basic romaine lettuce, tomatoes, and cucumbers. And those are the three things we need to tweak a little bit. So, and is that a weird analogy?
Yeah, you got it. But it was good. It was good.
There's a lot of pieces to the puzzle. There's a lot of ingredients to the pediatric feeding salad. That's the way I always look at it.
I got it. I made it. That was good.
I'm sorry, that was a leap, but I always have some sort of food analogy. So now you know.
It fits the,
Yes, it fits
setting.
exactly.
Wow. So obviously you've spoken already about some of your resources that are available. If you want to mention them a little bit more to our listeners in terms of if they want to learn more about you and your courses, and your handouts.
Thank you so much. My website is melaniepotock.com or mymunchbug.com. Same thing. For 25 something years, my feeding clients, I've always called them my little munch bugs, and that's how that name came to be.
That's
but I have all of my books, my most recent books on my website and where you can order them. I have the latest one is Responsive Feeding, which I'm really proud of. It's the only book of its kind on responsive feeding and typical feeding development, best for starting solids to about age 3. And then also my award-winning book, which is Raising a Healthy, Happy Eater, written with pediatrician Namali Fernando. We give out copies every year at the American Academy of Pediatrics. We're educating those pediatricians because we love them.
Yep.
That one is also on there, as well as several others in my children's book, etc. But my on-demand course library is there, as well as my live events. So I hope they'll check it out. And there's lots of free downloads as well. I would say the #1 resource is to follow me on Instagram, because I post every day there. So I hope everybody will do that. I'd love for them to join in on the conversation.
I follow your Instagram, and I do love all your content. And I think it's so impressive because you mentioned on your Instagram how it's kind of just you creating all of this, and you have a lot of creative content. So it's
Oh, thank you. I really appreciate that. My YouTube channel is another free resource. I'm not as good about posting there, but there are over 150 videos for people there as well. I'm a little better
Wow.
at about doing Instagram, but yeah, it's just me. I don't have an assistant. It is just me in my purple office.
I love it. I love it. I love it.
Thank you for joining us on this episode of Talk the Talk.
We hope it was enjoyable and educational and further supports you both personally and professionally.
For more information, please check out our Wyo Myo and Myo Minute podcast, as well as our other episodes of Talk the Talk. And don't forget to check out our tongue training appliance, Spot Pal, to help with tongue thrusting, thumb sucking, snoring, TMJ, mouth breathing, and so much more. Visit thespotpal.com.